Okay, so it's just gone 4 o'clock in the UK. So I will welcome you to this week's virtual ICEE environmental seminar. This week, the topic is very topical. It's related to the COVID-19 pandemic and the indirect and direct effects that has had on the healthcare professionals, particularly from a thermal standpoint. And this is obviously being held a year to the day, or a year to the week, that we initially locked down here in the UK. So we were just saying that we didn't think we'd be a year later, A, running a seminar series that was still going, and B, still in a pandemic and still in various forms of lockdown all around the world. But we are, so we may as well make the best of it. So some of you will already have attended, but just for those that haven't, this is the second season of the virtual seminar series. Season 1 had a number of speakers across a range of environmental extremes: heat, hypoxia, cold water swimming, a whole range of talks. And you can see there the speakers that we had in the first season. We then had a short break. We came back to season 2, which is what we're currently in. You can see that that wall is filling itself up nicely. And all of these talks are available on the ICE2021.com website, available there for free. And all the talks that are coming up will also be available there. If you go onto the website, what you'll see is that the talks are there, as you can see here in the video, but also many are accompanied with a teaching assistant handout. So a little screenshot there of the PDF. This has been put together by those that presented in that particular session, and it's designed to accompany the video in any sort of teaching capacity that you wish to use it for, providing a brief summary of the content, the key content of the talk, and perhaps some thought-provoking questions for you to explore either yourselves or as part of a group discussion in a lecture or a seminar, or what bit will also be it. To accompany the videos from this season, recently one of the co-organisers, who I always forget to introduce, Stephen Chung, and today Davey. One of the co-organisers, Stephen Chung, he's also been producing some short videos recently of a range of topics in environmental physiology, trying to give a more general audience a snapshot to some of the recent publications in the area. So you can also check those out. But today, as I say, we're on the COVID-19 health pandemic and related heat stress considerations. And we have two speakers who are going to deliver talks on that today. The first talk that you'll hear today will be from Dr. Sarah Davey. She's based in the Occupational and Environmental Physiology group at Coventry in the United Kingdom. And she'll be presenting some data and some information related to publication on the topic of thermal stress in healthcare workers. After Sarah's talk, there'll be a brief break for some questions. And then we'll have the second talk of today by Yannick de Korte from the Netherlands, who will be presenting some of his work that he's currently recently been undertaking and recently published. As with all the other sessions, we'll open up the question and answer function immediately. So during the talks, if you do have any questions, please use the Q&A tool to pose any questions. I will ask those to Sarah and or Yannick at the end of the slots. Please use the Q&A tool on the chat. That just means that we can manage that better and everyone can see what you are asking. That'd be fantastic. Okay. Thank you very much. So I'm going to stop doing that. And if I'd like to ask Sarah, please, to share your screen and take it away.
Yeah. Henry. Okay. So I'm assuming you can see my screen. There we go.
Yep,
excellent.
All good.
Okay. Well, firstly, I'd like to thank you all for taking some time out of your day to listen to this webinar. As Chris alluded to, what I'm going to do in this presentation is talk about the current challenges of occupational heat stress in healthcare facilities, and also talk about the results of a study that we recently published where we evaluated the heat stress that was experienced by healthcare workers, specifically in the NHS in the UK during the current pandemic. I want you all for a second is just to forget about the pandemic. Okay, I know it's quite hard to do, but let's all try. And over the next few slides, what I'm going to do is just talk about the general heat stress that is experienced in healthcare facilities. Now, I'm not sure if all of you are aware of this, but healthcare facilities are actually or should be strictly regulated. And there is and what I mean by strictly regulated, what I mean it's the environmental parameters. So that being temperature, relative humidity, and ventilation. And there are several international standards that provide recommendations for healthcare facilities to adhere to. And these recommendations are quite centered on maintaining the comfort of patients. The reason being is if you keep patients comfortable, it may enhance their recovery and shorten their stay in hospital. And there's a lot of evidence around that, but that's another presentation in itself. With regards to ventilation, there's strict guidelines there in order to prevent or reduce the rate of infection spreading. Okay, so in these guidelines, there's lots of guidelines for different rooms, which are basically centered around the patient's needs. So I've just put some examples on this slide, and these are based on the American standard, so ASHRAE 170, that were released in 2017, but they're quite similar to the British standards that hospitals would adhere to during the pandemic. So we've got operating theatres. They should be at a temperature around 20 to 24 degrees centigrade. In neonatal wards, they are a little higher at 22 to 26. And in physiotherapy or rehabilitation rooms, anywhere between 21 and 27 degrees centigrade. And during summer months, these guidelines can drift a little bit by about 1 to 2 degrees centigrade. And that's just to account for the fact that the occupants may become more acclimated to higher temperatures because they are experiencing higher ambient temperatures outside during those summer months. Okay, so I just want you to remember that these recommendations are quite patient-centric, okay? So when we place these environmental parameters into models that predict thermal comfort for occupants in any kind of rooms or facilities, and in these comfort models, we also use the parameters of clothing properties and metabolic rate. So if we take in consideration healthcare workers' clothing properties of what they wear and their metabolic rates, what we tend to find is they don't comply with international standards related to thermal comfort in workplaces which use these models. They don't tend to comply with those standards. So what you generally find in a healthcare facilities is that some healthcare workers are thermally comfortable, but the majority are thermally uncomfortable, because generally the environmental parameters are based or centered around the patient being comfortable, less so with regards to the staff. Okay. And what we also find is you may face different levels of thermal comfort within the hospital itself, but you might also find different levels of thermal comfort between the occupants in just one room itself. And a really good example of this is the operating theatre. Now, in an operating theatre, the environmental parameters should be strictly regulated, and I provided the environmental parameters here. And also we've got the issue of the fact that they use surgical luminaires, which can provide quite a high radiant heat load. So this is centered on the patient, but also the surgeons, and it can be akin to being exposed to the sun on a quite a hot sunny day. Okay, so we're causing quite a microclimate for the surgeon. But also in an operating theatre, you have quite a few different members of the team: the anaesthetist, the nurse, we have the surgeon, we might have some surgery assistants, and they all wear different type levels of PPE, but they also have different metabolic rates. Okay, so what we often find, and we were actually just discussing this just before the webinar started, is that you may have some of that team feeling really cold and uncomfortable, and some feeling quite hot and uncomfortable. And this study by, I hope I'm saying this right, Davey and al. in 2014 nicely illustrates this. And so what they did was they modeled the thermal comfort based on the environmental parameters of an operating theatre, and also the clothing properties and the metabolic rate of each members of a standard operating theatre team. And they used the Fanger's model of thermal comfort, which is used in the ISO standard of 7730, to predict how comfortable and how hot or cold these healthcare workers felt. So these are the results of their simulation. So on the y-axis, we have what we call the predicted mean vote of their thermal sensation. And anywhere between minus 0.5 and 0.5, it is perceived that the occupant will feel comfortable. Anything outside those parameters, they're either uncomfortably cold or uncomfortably warm. On the x-axis, what we have is the prediction of how many people in that room will feel dissatisfied with that temperature or the environmental parameters. So as you can see, the nurse is feeling uncomfortably cold, and the surgeon is feeling uncomfortably warm, because the surgeon has got a higher level of PPE, so they've got higher insulation properties, but also they have higher metabolic rate. Which is why what you'll tend to see when we're looking over occupational heat stress in healthcare settings, they mainly concentrate on the surgeons, and you'll see that quite commonly in the literature. Now, what was quite nice is this, the authors of this study then went on to predict of what kind of parameters are required to make sure that all members of that team are comfortable. And so what they predicted is for the surgeons who are wearing a higher level of PPE and higher metabolic rates, that the air temperature should be around between 13 to 16 degrees centigrade. And the nurse and the anaesthetist just need to wear more clothing, or of a higher insulation level, sorry. So this is okay for the nurse and the anaesthetist, but unfortunately for the surgeons, this is a no-go, because once we start getting to temperatures below 18 degrees centigrade, you're increasing the chances of the patient becoming hypothermic. So that's not allowed, we can't do that. So at the end of the day, in an operating theatre, you are going to have surgeons who are going to be uncomfortably warm due to the heat stress that they're experienced. And this doesn't even take in consideration of the radiant heat load that they're exposed to. I just need to add. Okay, so in general, we see this quite often, of this conflict of some healthcare workers being comfortable and some experiencing heat stress. Now, in the UK, this is going to be even more of a challenge due to the more recent episodic heat waves that we are experiencing. So over the last 10 years, this has become more frequent. And what we often find is that cases of overheating is occurring in hospitals. And what this means is basically instances where rooms in healthcare facilities are exceeding temperatures of 28 degrees centigrade. And there's quite a few published studies that have demonstrated that some rooms during the summer months can exceed 30 degrees centigrade, okay, which could cause quite a lot of heat stress when we think about it when people are wearing PPE. Now let's return to the pandemic. So what's happened because of the pandemic and the increased usage of PPE by healthcare workers, and also the increased level of PPE that healthcare workers have had to wear, this has really started to increase the problem that already exists, but maybe increased the level of heat stress, but also the majority of care workers who are actually experiencing heat stress. So we've seen that in the media, and that's really increased the awareness, but also we're starting to see more anecdotal evidence from the healthcare workers themselves. So our team at Coventry wanted to start putting some evidence behind those anecdotes, which led on to the study that I said I'd describe or discuss. So in our study, what we wanted to do is use a survey-based design to start to evaluate the actual perceived levels of heat strain and its consequences in healthcare workers required to wear PPE during the pandemic. And we specifically just looked at the National Health Service within the UK. And what we really wanted to look at is the consequence of heat stress experienced when wearing PPE on the cognitive and physical performance of healthcare workers and their health and well-being. Now, when we did this study, we did collaborate with our local hospital, and some of the clinicians wanted to also look at the effect of heat stress and the number of occurrences PPE was taken off due to overheating, as they believed it might increase the healthcare's risk of infection of COVID-19. There's a lot of studies that have shown that frequent donning and doffing of PPE is sometimes done inappropriately, and this, if it's not done appropriately, that's when infections occur. So we wanted to explore that too in this survey. So what we did is we produced quite a short survey, so just 23 questions. And we kept it quite short because we were advised if a survey is any more than 15 minutes, healthcare workers won't do it. They're too stressed as it is. They don't want to spend any more time doing a survey. So we tried to keep it quite streamlined. We distributed it with our local NHS trust and also other NHS settings. And we did this between May and August last year, so our summer months in the UK. So the external ambient temperatures were between a daily average between 18 to 22 degrees centigrade, with the maximum occurring in August of 35 degrees centigrade, which is our heat waves. We assessed many variables. I'm not going to go through all of them, as I'm going to discuss them in the results in the next slides. But what we did also want to do is to see the effect of the two different types of PPE that are generally worn in NHS settings. So we have type 1 PPE, which is the more thermally stressful type of PPE, because it's the kind of PPE that you see in ICU units, where they've got full coverage mostly, and they've got fluid repellent long gowns, which are have quite high evaporative resistance, so increases the heat stress on that healthcare worker. And we just compared it with the type 2, which are less thermally stressful, as depicted in this picture here. So I'll just go through the key findings. First, I just want to highlight that we got 224 respondents and the majority were female. And this is probably quite reflective of the demographics of our NHS staff population, but also the fact that usually females don't mind filling out questionnaires where males are less likely to do so. Of our respondents, most of them wore the less thermally challenging PPE. So just remember that when I go through these results. The actual number of hours that the PPE was worn, the majority of respondents wore them for more than 4 hours. And what we did find was some respondents were wearing PPE for more than 12 hours. So basically their whole shift. What we wanted to do to maybe inform future studies or policy itself is just to examine any associations with the type of PPE worn and the number of hours worn on the factors of health and well-being and infection control. So we used the chi-square statistic, and we found that the number of hours of PPE being worn, not surprisingly, was associated with the thermal perceptions, a change in sweating, the number of heat stress symptoms experienced, and also the frequency of PPE being removed due to discomfort, okay, and more thermal discomfort. Okay, we did not find any associations with the type of PPE worn, but that's probably due to because we have this unequal balance between type 1 and type 2 worn by the respondents. Okay. So we look at the thermal perceptions themselves. So remember, they wore the less thermally, most of them wore the less thermally challenging PPE, but we still found that 72% felt hot, and about 90% felt uncomfortable or very uncomfortable. And this is probably what resulted in about over 50% of the respondents advising that they did remove the PPE due to feelings of feeling overheated or thermal discomfort. And so what we found is that a quarter of those respondents would remove their PPE on 5 or more occasions, which could increase their risk of infection if it's not donned or doffed appropriately. If we look at the heat-related illnesses, so 65% of our respondents did say they experienced at least 3 heat-related illnesses, with the majority experiencing fatigue or headache. However, what is quite concerning is that we did have 40% of respondents saying they felt dizzy, and some respondents experienced fainting or confusion, which if we look at the health and safety aspect, that is quite concerning, because it could cause injuries to themselves or the patient, but also it affects productivity or performance. Now, if we look at cognitive performance, the majority of respondents experienced at least one cognitive task being adversely affected, and quite akin to most studies that examine heat stress and association with cognition. The tasks that were impaired the most or reported to be impaired the most were the more complex tasks. So making decisions and solving complex problems, and the participants reporting that their attentional focus was mainly impaired. However, I want you to put this in context of the current pandemic. At the time last year, remember, the COVID-19 virus was a new disease. So healthcare workers on a regular basis or even a daily basis were making quite hard decisions and having to solve quite complex problems. So if this was impaired, this is quite an issue in this situation, okay? Now we go to physical performance. Now in these questions, we just asked about PPE itself, not specifically the heat stress experience whilst wearing PPE. And the 65% at least of the respondents said that their physical performance was impaired, and they perceived that their job-related tasks become slightly more difficult. So in our survey, we also included an open text comment box where the respondents could just say anything they wanted in regard to how PPE affected their working life, which hadn't been already captured in the survey. And we were quite surprised, and the clinicians who've done quite a lot of questionnaires were surprised by the amount of comments, but also the depth and breadth of comments that were received. So this is just one of the comments that we received, and I just want you to have a look at it because it really depicts how some of the healthcare workers what they were experiencing during the pandemic, specifically related to wearing PPE. So we got several more comments similar to what this clinical sister was saying, but I did want to just highlight one sentence that she did say, and this is regards where she alludes to the fact that regardless of the pandemic, in the ICU unit, they do actually suffer from occupational heat stress. So it does highlight that this is an issue regardless of the pandemic. Okay. Because we had such breadth of comments and the content was quite rich, we decided to do a thematic analysis on these comments. And from the thematic analysis, it did really highlight the two main issues that the healthcare workers experienced related to PPE. And that was obviously heat stress, because that was the point of the survey came up. But also they commented quite a lot on certain individual items of PPE. I'm just going to talk about a little bit of the heat stress comments. Most of it was captured in the survey, but I just wanted to highlight that there were respondents did comment about when in the summer months, it did make it more unbearable wearing PPE in hospitals. But also we had some respondents who were suffering from or undergoing menopause, that wearing PPE worsened their symptoms, and some of them stated it made them unbearable to cope with. In regards to the individual items of PPE, the mask and the visor were the most commented upon, which basically concurs or supports other survey-based studies that came out at a similar time, and also in response to the Ebola crisis in 2014-2016. And so it was the mask and the visor that were the common issues related to those individual items of PPE, with the mask causing problems with breathing and markedly communication. And this was quite concerning for the respondents, as they felt that they can't communicate with their patients, especially vulnerable patients, such as the older patients or those with hearing impairments or suffering some form of mental disorder. The visor, it did affect their visibility, mainly due to fogging of the visor. A lot of the comments also could be categorized and how the PPE affect their working life. And I'm just going to highlight these three because the others kind of captured in the survey itself. There was a lot of comments where the healthcare workers felt conflicted. The PPE was making them feel uncomfortable, but they knew they needed to wear it to protect themselves against COVID-19, which is what we often see in occupations that are required to wear PPE. The workers are sometimes happy to put up with the discomfort if they know the PPE will protect them against the threat that they experience, in this case, COVID-19. A lot of the comments were also covering the umbrella where they're really concerned about PPE affecting their ability to care for their patients in the manner that they used to be able to do. And that kind of stressed them out a little bit. And also there was a lot of emotive comments with regards to the facial conditions that they're experiencing because of the face mask. So this is contact dermatitis, but also acne, especially from our younger doctors and nurses. We did have some comments where they wanted to see changes in the policy regarding wearing PPE in the workplace. So there were comments where they really wanted to, were requesting different designs of PPE. They wanted more breaks, and they wanted being more able to hydrate. So hydration were often cropped up in these open comments. There were concerns about how hot the environment was, which goes back to what I was talking about at the beginning of the presentation. And they were concerned about how long they had to wear the PPE for. So to kind of conclude, the key messages from our survey-based study were the following. And I want you just to bear in mind, again, that 72% of response were the less thermally challenging PPE. So some of the results could be not really depicting what might be happening in an IC unit, for example. So all the respondents reported experienced some level of discomfort. And it's quite commonly known that discomfort can be associated with lower job satisfaction, but also productivity, but also impaired cognition, which is quite important. Also, 2/3 reported that it removed PPE in a shift, increasing their risk of infection. Possibly. We need more research to determine that. And this is quite important, as it has been reported that healthcare workers in the US and UK are 3 times more likely for testing positive for COVID-19. There could be a link there, but we don't know. At least 3 heat-related illness symptoms were experienced, with headache being the most common, but we did see fainting and dizziness. What would be interesting is to examine the impact of chronic exposure to the heat stress, so this type of heat stress, on healthcare workers' health in general. We must acknowledge that individual items of PPE impact healthcare workers' working lives independent of heat stress. However, heat stress could actually attenuate some of these issues. So, for example, fogging in the goggles, but also some of the breathing complications regarding to the mask and some of this contact dermatitis. Finally, and this is quite important, is the open comments suggest that some healthcare workers vulnerable to heat stress may be more impacted by the requirement to wear PPE. So other example populations are diabetics, older workers, and obese healthcare workers. So that'd be useful to look in the future. Like every study, we have limitations. So the big one being we're only looking at perceptual heat stress, and we need more objective measures, but Yannick will discuss this, so I leave that to him. We can't conclude whether the frequency of PPE removal due to heat stress jeopardise the respondents' infection or risk of infection. We need to examine that further, and our collaborators are really interested in this. We did not capture whether any of the respondents actually used any heat stress mitigation strategies. So we don't know if that actually influenced our results in any way. So we're missing that information. Another really important thing is we didn't capture any other kind of stresses that our healthcare workers were encountering at the time, which could actually influence the results also. And what I mean by that is in the open comments, 13.4% of these comments reported that their healthcare workers or the respondents' mental well-being, physical well-being had been affected by wearing PPE. However, if you think about it, healthcare workers, especially during the pandemic, were undergoing a lot of stresses, and some of these stresses are outlined here. So at the end of the day, the thermal discomfort is only one of those stresses. And we may have all experienced this, but the literature suggests this. When you have a lot of stresses, you've only got a limited amount of coping strategies. So you can become more hypersensitive to certain stresses because it's overloading you. It's that one thing that's basically the icing on the cake. and therefore they could have exaggerated how uncomfortable they felt, if that makes sense. But anyway, by the by, it still exists, and this is the situation. So if we can reduce or eliminate this stress, at the end of the day, it could increase the well-being of healthcare workers, because it helps them to cope with these other multitude of stresses that they're experiencing at the time. So it still is really important to hopefully increase their well-being overall. So as you can tell, I find this really important, this work, even regardless of the pandemic itself. I really see more work being done in this area. And what would be really important to do is actually just to characterise the heat, stress and strain experienced by healthcare workers in numerous NHS settings, but also compare this to other countries and what they experience, just so we have a better understanding of the extent of the problem, but also how we can solve this problem. So we're going to start doing this up in Coventry. And if anyone else wants to do it in other countries, then please get in touch. Or if you're currently doing it, it'd be good to collaborate on this part of work. Also, extending upon that, it'd be really interesting to characterise the heat, stress and strain in certain population of healthcare workers that are vulnerable to heat stress, so diabetics, older workers, and more obese workers. Something that we really need to do is actually look at the impact of thermal strain when PPE worn is on clinical performance and cognitive performance, and really get some more objective measures around that, and simulating what actually is happening in the field and put it into a lab situation to do that. And we have a PhD student who's currently doing this at the moment. Also looked about the impact of chronic heat stress exposure on health and well-being of healthcare workers. And this work is already started doing, so Yannick's going to talk about this. But it'd be good to start to really looking at how effective certain cooling strategies that we use in other settings and other occupational settings and sports settings, how effective they can be used in healthcare facilities, basically. And finally, should we start looking at redesigning PPE? I know this is hard because we've always got that conflict of protection versus comfort, but maybe we need to do some more work with regards to PPE related to more healthcare settings. And that's me done. But before I take any questions, I do want to give a big thank you to both Doug Fake and Ben Lee, who are part of the Occupational Environmental Performance Group at Coventry University, and also our collaborators at the University Hospital Coventry and Warwick NHS Trust, so Dr. Tim Robbins and Dr. Harpal Randiva, who helped us give the clinical side to our study and also helping us with our future work in this area. Yeah, and if anyone wants to collaborate on this, then please do get in touch. So thank you.
Thank you, Sarah. Thank you for that overview of the topic and of your study. Very interesting. One of the things that kept sort of resonating with me is how it's not pandemic specific, although it's definitely come to the fore during the pandemic. And you alluded to it quite a few times throughout the talk, but outside the intensive care units, how much of a problem do you think it would be in a normal time? So what's a typical healthcare worker's sort of heat stress day to day outside a pandemic look like? Do you know?
So when you, if you mean, we don't have many objective measures, and this is where is more subjective assessment. So it's more thermal comfort related studies that have evaluated thermal comfort in buildings, healthcare facilities per se. So that's the evidence we're kind of lacking at the moment. But based on those thermal comfort studies and some of the objective measures that have been taken, they experience quite moderate heat strain. And what I perceive where it might be more of an issue is those cases of where we've got those heat waves. So if we want an actual core temperature value, what we see is in the less thermally stressful PPE, okay, so even just wearing scrubs or level, the type 2 that I was talking about, you might be seeing anywhere between 37 to 38.5, depending on the duration. However, this needs to be more evaluated during the hot summer months on episodes of where we see overheating in hospitals. So there's a bit unknown there. Yeah, at the higher levels of PPE, you can see core temperatures raising above 38.5. So in that kind of type 1 PPE. But what's more interesting that we want to examine is the length of time that they are over, say, 38 degrees centigrade. And the long term of exposure, influence of being exposed to those temperatures over a week per se, rather than just 1 day. And I think it could be that accumulated effect that could influence healthcare workers' health and performance. So it's a bit unknown, but yeah, thermal comfort studies suggest, as of what I alluded to at the beginning, that the summer months are probably more of an issue rather than the winter months in the UK.
Yeah, thank you. Linked to that, actually, linked to this sort of the chronic exposure, I've got a question from Cohen Bongers from the Netherlands. Hi, Sarah, thanks for a nice presentation. You've collected your data in the summer months in the UK, which always seems like a bit of a dig. We do have a summer sometimes. Whereas presumably the environmental temperature within hospitals was a bit higher compared to winter. Essentially, what Cohen's asking is whether you think there is enough on the job heat acclimation to perhaps mitigate some of the risk during the warmer months, which therefore might put some of the individuals at actually a greater risk when it's a bit cooler, when there may be some sort of less acclimatizations going on. Do you have any thoughts on that?
Yeah, and this is something that we want to investigate, especially what will be interesting is at the beginning of our summer months, so whatever we perceive that to be, when they're not acclimated, and that would be where we'd really want to capture that information and see how they're coping, say, for example, for us in May in comparison to July. But so yeah, so it's just not, there's not enough evidence there to know. But that's something that we want to explore at Coventry. This PhD student is basically looking to examine. The only complexity of it is trying to make sure that our, just bearing in mind the acclimation status is sometimes harder to control in the field settings, if you see what I mean. Mm-hmm.
Yeah, absolutely. Yeah, it seems like it's an area that's ripe for some quantitative data. Last question before we pass over, just to kind of lead into the next talk, actually, is you said your questionnaire didn't capture any mitigation or combat strategies. That's not what it was designed for. But in your talk, in your conversations with members at the NHS, are you aware of anything that the local NHSs have been using as a way to try and minimize heat stress?
Yeah, so there are guidelines, but it depends how well, this might sound a bit political, so I've got to be careful. It depends how well each healthcare facility or even the healthcare worker itself. Remember, we're talking about workers who's mainly driven by looking after patients. So sometimes they don't adhere to those policies based on the situation they're working on. So there are work-rest ratios that are, especially in ICU units, that the healthcare workers should adhere to. So there are some there. They should have access to water to hydrate, and there are recommendations that they should have cooling rooms, but more for the patients, that should be kept below 26 degrees where they should cool down. But something that we're quite interesting to capture is, one, do those heat stress policy exist in all NHS trusts, but also how aware the healthcare workers are of these policy, but also how well they're adhered to. It's a very complex and challenging, high-performing environment. So there's always going to be, these things are not always going to be adhered to. And what was quite interesting was that doctors seem to have the ability and to adhere to these policies, where nurses are less able to, because they have their responsibilities full-time on the patients. So there was a bit of disparity there, which good to investigate.
I think that was very tactfully answered. Excellent. Thank you very much. That kind of leads us in very nicely. So thank you very much for that talk. So if you'd just like to stop sharing your screen, please, I'd like to invite Yannick, please, to share your screen, where hopefully we'll be provided with a little bit more data about a heat mitigation strategy or two.
Yeah. I'll just remove you here. Okay, yeah, thank you, Chris, for the introduction and also the chance to share our data on this seminar series. My name is Yannick de Korte, and I work as a PhD student at the Department of Physiology in the Netherlands. And I will share data of a project I conducted together with my team, so Koen, Milan, Boris, and Thijs. And it will be about cooling vests to alleviate perceptual heat strain in COVID-19 nurses. Oh, can I remove this? Do you also see something on the title, or can you read the title?
We can see the title.
Okay, then it's just my screen. Okay, perfect. I will continue. So as we all know now that during infectious disease outbreaks, healthcare personnel use personal protective equipment to safely perform their medical duties. But the downside is it also creates an insulated microclimate around the skin, and that leads to an impairment of heat loss capacities. And well, it increases heat stress levels, and that may induce heat strain. Well, the link between PPI use and PPE use and heat strain is well established and well known. And in healthcare, it's clearly illustrated during the West African Ebola outbreak in 2014. And the World Health Organization stated that personal protective equipment is hot and cumbersome, especially in a tropical climate. And this severely limits the time that doctors and nurses can work in an isolation ward. And in other studies, it was stated that patient contact was limited to only 40 to 60 minutes in order to cope with the heat. So a lesson learned from the Ebola outbreak was that well, the heat and in combination with PPE use threatens the health, well-being, and also productivity of healthcare workers. And that at that time constrained the disease control. Well, then you could argue, okay, is this only a problem in a tropical climate? Well, we just saw the talk by Sarah, so we know the answer now. But during the early stages of the pandemic, we also collected some anecdotal evidence, and that made clear to us. Well, heat strain, PPE-induced heat strain is not only an issue in tropical climates. And well, besides issues on vision, mobility, and communication, the things that we most heard were high sweat rates, increased exertion and thermal discomfort. And we thought, okay, this is an issue because we know that sensory displeasure may impair effective decision making. And that's not what you want, especially not in a medical setting. And then if we look at solutions, Sarah also said something about this. The most common heard solutions are to adjust your work and rest schedule. Well, maybe this is obviously a good option, but maybe not always feasible, especially not during the peaks of the COVID pandemic, where workload is really high and maybe also hospitals are maybe understaffed. Another solution during the Ebola outbreak was suggested to increase the ventilation in PPE. And well, this is also I don't think this is a good option for during the COVID pandemic due to its high transmission in air. So maybe, yeah, redesigning a PPE at the manufacturer level remains. But we thought at that time, okay, all these solutions will obviously take time. Is there not something that we can do now? So we asked ourselves the questions: what can we do now, together with the occupational physician responsible for the COVID wards within our hospital? And to give you a bit of background, normally we perform with our team, we perform this kind of research. So this is a picture of our Thermo Tokyo project, in which we investigate exercise performance and thermoregulation in athletes. And what we also do in this project is looking at ways, what's also written on the wall here, ways to beat the heat. And we thought, okay, can't we translate this knowledge from sports science into medical science? And well, if you translate this science or look at ways we beat the heat in sports science, there are three major strategies. And these are acclimation, hydration, and cooling interventions. But then if you're trying to translate this to a medical setting, we don't think that acclimation is really a good strategy. Maybe natural acclimation will occur, what we just spoke about after Sarah's talk, but as a strategy to improve maybe make the conditions more comfortable, we don't think that's a good solution. And I think the same accounts for hydration. Hydration is obviously important, and heat stress or dehydration is a common consequence of heat stress. So logically, healthcare workers should have easy access to water during breaks and stuff. But during their work, there's restriction in fluid intake because they use a mask. So this is maybe also not the perfect solution for improving making their working conditions more comfortable during work. So we said, okay, maybe the cooling interventions are then the best option. And we made an infographic about translating this knowledge from sport to medical science. And we published that in the BGSM. And one of the things we discussed in this infographic is what cooling intervention should, what criteria they should meet before you can implement them. And well, as written here, they should be safe and hygienic. They should be rapidly scalable, and really, really important, they should be easy to use, but also very easy to implement, because otherwise, well, we can invent a lot of stuff in the lab, but if it's not easy to implement and easy to use, it will never be used in practice. We also discussed, or we said something about timing of cooling, and we discussed, we said, okay, you can apply per cooling, and then you can use, for example, ice slurry ingestion and cooling vests, because those two are known to alleviate heat strain quite effectively. But if you look at per cooling, so during work, well, we said, okay, then you should use a cooling vest, and after work, obviously, you can also use both. but good to mention that ice slurry ingestion, it has been demonstrated that the positive effect eases away after 20 minutes. So, well, depending on how long this period is, 20 minutes is probably not enough. We just saw the hours they work in the UK in the talk of Sarah. So maybe 20 minutes is not enough. And we said, okay, if we want to improve the working conditions during their work, we should focus on per cooling strategy, so cooling fasts. But then if you say, okay, we're going to use cooling fast, you have a lot of options on what cooling fast you can use. So, for example, there are active cooling fasts, like water perfused suits. There are also fasts that work on evaporation. And you have the conduction cooling fasts, so as the PCM, phase change material cooling fasts. And if we then think back of the criteria we published in then maybe the first one is, well, it's not very easy to use, and also we think not easy to implement, so that's not a good option. And then we have the evaporation. You don't want to evaporate a lot of or create a lot of water vapor underneath your PPE. So maybe also evaporation is not a good option. So we said we go for the phase change material cooling fasts. But if you use phase change material cooling fast, you always have the trade-off between on one side cooling power, and on the other side the cooling duration. And to illustrate this, for example, during the or for the athletes of the picture, the Thermo Tokyo project I just showed you a picture of, we designed a cooling fast that has a really high cooling power, but very short duration, so aggressive cooling. And in sports science, you can think of this as a pre-cooling strategy, really short and really aggressive, but way too aggressive, and duration very way too short to be used in a medical setting. And I think the same accounts for the 15-degree cooling fast. So still duration pretty short, and the cooling power too high to wear it for a couple of hours. Then we had the 21-degree cooling fast, and that has a pretty nice combination of cooling duration and also cooling power. And the 24-degree cooling fast. Well, we tried those two. We pilot tested those. And shortly, the 24-degree cooling fast, the cooling power was just not enough to provide sufficient cooling. So therefore, we decided to go for the 21-degree cooling fast. The company that makes those fasts, Dutch company Unitech, they said the cooling fast will provide cooling for 3 hours, and we assessed that. We looked at that, and if you see the cooling fast temperature over time, and then if we get the cooling fast out of the fridge, well, at first it's around 6 degrees, and then after around 30 minutes, it's around 20 degrees, and then it remains quite nicely around 20 degrees. And maybe for the last 30 minutes, it starts increasing a bit. But what is good to mention is that, of course, your skin temperature will be higher than the temperature seen here. So there will always be within this 3-hour time frame, there will always be a delta between your skin temperature and the cooling fast temperature. So then we can say, okay, the cooling fast will provide cooling for 2.5, so maybe up to 3 hours. So that was the start of our study and our COVID study, in which we had 2 questions. The first question was what is the perceptual and physiological heat strain encountered by COVID-19 nurses wearing PPE during real-life work shifts? And the second question was, okay, what is the effectiveness of wearing that 21-degree cooling vest on perceptual and physiological outcomes? And to look at it, we conducted a study in 17 nurses. And these nurses were on average 31 years old. They were all Dutch, so probably pretty tall. And they had a normal weight and a normal BMI. And we monitored them on 2 days, a control day and a cooling vest day. And on the cooling vest day, the intervention day, we gave them a cooling vest every time they used the PPE. The working days, at least in our hospital at the COVID wards, looked like this. So they had 3 work bouts separated by 2 half-hour breaks. And as I said, we were interested in perceptual heat strain. So we asked them to score their perceptual heat strain after each work bout. And we so directly after they doffed off their PPE, we asked them to score. And they filled in questions on thermal perception or thermal comfort, thermal sensation, and RPE, rate of perceived exertion. And for the second part, we also looked at the physiological heat strain, and we measured their core temperature using the E Celsius system. And we also measured their heart rate using a polar system. We measured this continuously throughout the day. And besides that, we also assessed the ambient temperature, so the temperature at the COVID wards, and we also measured the temperature underneath the protective clothing. And maybe good to mention, we obviously randomized the order of the two days. So if we go to the results, the ambient temperature at the COVID wards was 23 degrees, and the insulation by PPE resulted in higher temperatures, so PPE air temperatures, with peak values up to 32 degrees. And these are new results, but I think they perfectly align what's already written in published in recently published, and that they suggested that the air temperature underneath PPI is high and contains more water vapor, and that this this can result in already thermoregulatory challenges at 22 degrees. So I think the first finding of our study was, okay, the increased insulation by PPE results in substantial sub-PPE air temperatures. Then if we go to the physiological outcomes, and we start off with the core temperature values. And we have the average core temperature on this side and the peak core temperature on this side. And we have the 3 work bouts for the control condition. Well, what you see immediately is that we didn't observe high core temperature values. There was a small increase, but on average, well, it's below 37.5. And if we look at the peak values, they were also not very high. And I think the same accounts for the heart rate. And I have to say, we were maybe a bit surprised that the average heart rate values were this low. I expected them to be a bit higher, and the same for the peak heart rate values. But yeah, maybe or what we can say about this is that the physiological heat strain among nurses using PPE in moderate conditions is relatively low. If we then continue and look at the cooling vest effect, so now we have the work about 1, 2, and 3 of the cooling vest day. Well, there you see that there's not big of a big change, and there's also not an overall effect between conditions, but there is an interaction effect, and you see that there is a small increase over time on this side with the highest temperature during the 3rd work bout, and there's, well, at least another pattern, a different pattern on the control or in the cooling vest day, and we see the same for the peak core temperature values. For the average heart rate, it was just a bit lower. Well, really small differences. and for the peak heart rate, we didn't observe any difference between the 2 days. So by this, we can say that the use of a cooling fast has limited effect on physiological heat strain outcomes. And maybe, at least in this study, the physiological heat strain is not a major issue. Because if we then continue to the perceptual outcomes, and on this side we have the thermal comfort, and on this side thermal sensation, and we start with the thermal comfort score, which is a 4-point scale ranging from comfortable to very uncomfortable. And here you see the percentage of participants that scored gave a specific score. And then you see that there's not a lot of green, especially in the third work bout. You see that around 20% of participants gave a comfortable score, and that the majority of participants scored slightly uncomfortable to very uncomfortable. And well, a similar pattern is can be seen in the thermal sensation, which is a 7-point scale ranging from cold, neutral to hot. And here you see also not very much of the green color, but a lot of yellow and orange. The RPE score they didn't change over time and was 4.1 on average for the whole day. So by this we said, okay, PPE use provoked substantial perceptual heat strain, as the large majority reported thermal discomfort and a slightly warm thermal sensation. Well, if we then continue to the cooling fast effect, what you immediately see is that there is a big change in the color of green, so a lot more comfortable scores in the cooling fast day. And well, you see that around 20% still scores a slightly uncomfortable, but that the majority scores comfortable. And we see a similar pattern in the thermal sensation scores, that there is a lot less orange and yellow, and there is more green, and even the introduction of slightly cool and cool. So here you see that, well, 35% still says, okay, I feel slightly warm, and the rest says, okay, I feel neutral or up to cool. And it's good to mention that almost all people that are giving the score cool or slightly cool are also in the comfortable group on this side. We didn't saw any differences in RPE score between conditions. So by this we concluded that the use of a cooling vest can successfully alleviate thermal discomfort and slightly warm thermal sensations. Well, if we put these results in perspective, then well, the perceptual heat strain, it's substantial, and that perfectly aligns with the previous talk, and also some other reports in China. So this is, yeah, I think a serious issue, especially during the COVID pandemic. And on the effectiveness of the cooling vest, we already knew that per-cooling can reduce perceptual heat strain in occupational settings. And we also know that back and face cooling is most effective on improving thermal comfort. And we believe that every cooling solution is scenario specific, but at least for this specific COVID condition, we can add to that 21-degree PCM cooling vest can successfully alleviate perceptual heat strain in COVID nurses using PPE. And this potentially leads to extends in work tolerance time, improvements in physical and cognitive performance, and also maybe improvements in recovery and reduction of fatigue. So therefore, we advise to use these cooling vests in the COVID care, and to strengthen this message, we designed an infographic and that's seen here. And this infographic clearly illustrates that if you have the cooling vest, you buy it once and you add it to the cycle of work, then it can continuously go with the cycle. So if you have the cooling vest, you activate it in a fridge, and then if you start donning, you place the vest over your standard medical scrub, but underneath your PPE. And then you're ready to work, and you have cooling for up to 3 hours. And afterwards, you remove and disinfect and reactivate it again. And then, well, you have the continuous cycle. So the take and the keep home message. COVID-19 nurses wearing PPE during real-life work shifts encounter limited physiological heat strain, but substantial perceptual heat strain. And the use of a PCM cooling vest can successfully alleviate this perceptual heat strain during the ongoing COVID pandemic, but maybe also beyond. Our paper is published in Temperature, and it's open access. So if you want to read more about our study, you can find it over there. And by that, I want to thank you all for listening, and I'm willing to answer some questions.
Thank you very much, Yannick. Very nice presentation and some really excellent figures in that. Very well demonstrated and illustrated. A couple of quick questions, first of all, about the vest before we get into the study. When you did the 3 hour, or when you were sort of testing the claim that it could cool for 3 hours,
yeah,
was that done whilst people were wearing it, or was that an ambient test, or how did you test the 3 hour duration?
Yeah, so that was one person wearing the vest, yeah, and doing some low intensity work. Yeah.
Cool. So it was in contact with a human.
Yeah.
And I might have missed it, but what does it weigh? Because sometimes one of the issues is like the mass of these things.
Well, that's a good question. It's pretty light. I don't recall the exact number, but I thought around 1.5 kilograms activated. Yeah.
Okay, that's quite light, because obviously one of the things, if you wear it for a long time, it could have unwanted negative consequences as well. But that's interesting. That's quite light with quite a lot of cooling. I just wonder whether you could maybe comment, because obviously you found that your participants had quite a low level of physiological strain. Do you have any reasons to think why? Do you think that is representative, or is it your particular population group, or what do you think?
Well, I actually had a figure. I thought I didn't have time to discuss this, but if we look at our study, we had a 23-degree temperature, and the duration was around 150 minutes. And the highest temperature, core temperatures re-recorded was 37.7, and peak heart rates were around 109. If we then look at a study in Ebola, also a field study, way higher temperatures, shorter duration, but also maybe not really high core temperature values. And well, what I think is important here is that the maximal heart rate values that we see are quite almost identical. So I think that typically the work they do is intermittent and at low intensity, and maybe they're just doing their normal work. So behavioral thermoregulation is also involved, of course. So I think it's that is the main reason. I think the low intensity they work.
Thank you. Boris says it's 1.4 kilograms, the vest.
Chris, may I jump in here with a follow-up question to that?
Certainly can.
I guess related to the weight and also the use long-term and what you just said about pacing, Yannick, I don't assume you had any kind of comments, or was there any feedback about whether it was constrictive, because obviously with conductive cooling, you need it to be fairly tight and close to the body. So did you get any kind of discomfort or just annoyance kind of feedback from participants about wearing something fairly tight for the 3 hours? And then also related to your comment about pacing, that is a very powerful way of thermal regulating. So, did the individuals in the cooling trial, did they end up doing kind of less work in a sense? Did they do less, go slower? Was there any kind of feedback in terms of that?
Well, to answer your second question first, no, we didn't receive. Well, we assessed the RPE, so the level of exertion, and there was no difference in that. We unfortunately were unable to detect, for example, that on an objective measure the activity they did. But maybe they did more during the cooling vest condition. We don't know, so we don't have data on that. And related to your first question about wearing a cooling vest for 3 hours under these conditions, most of the participants say they really like the cooling, and that it was good, subtle, but good for them. But we also got some participants that had a higher sweat rate, and there if you start sweating, then maybe it's not really comfortable to wear a cooling vest that close to your body. But I think that also relates to the intensity you work in and how much you sweat. And generally speaking, in our population, we almost got only positive feedback about this cooling vest.
Great,
yeah, we obviously know how important improvements in perceptual strain are for self-regulated work. So you got some very dramatic improvements in that. So excellent. I think T, did you say you had a question?
Yeah, just briefly. Thanks, Yannick, for a really nice work and a really nice presentation. So I liked it a lot. I guess I might have missed, but were there females and males included, or?
Yeah.
Yeah. Okay. Yeah, so and my question goes along with Stephen's one, and in particular, were there any differences between females and males in terms of how they subjectively, perceived if the vests are nice, to wear? And because we saw the perception was obviously the thermal aspect was really nice, but you also mentioned that most of them liked it. Was it the same for males and females, or was the design of the vest the same used, or?
Well, yeah, the design of the vest was exactly the same. So there was just one size, and you can adjust it on the side to make it a good fit. There were no real differences between men and women, but the person I was talking about with the highest sweat rate, that was a man. So yeah, maybe there are differences if you have a bigger group, but we had I think 3 or 4 men. So, well, we didn't really detect any differences on the perceptual.
Yeah. Okay, thanks a lot. And more of a comment, and I think that it's in a way it's interesting to see the dissonance between the physiological, measures that were kind of more or less, comparable, and this big subjective feeling, which is obviously in this stressing environment and working environment really important. So I think it's great if we manage, only through the perceived improvements, kind of keep up the good spirits in a way. Yeah? So yeah, thanks a lot. Yeah.
Thank you.
Definitely, and it's definitely an area where you want the people to be making good, correct decisions, isn't it?
Yeah.
If you're in hospital, you want them to be doing all right. Well, thank you very much, Yannick, and thank you very much, Sarah, beforehand. A very interesting and very topical presentation, and I think it's a topic, obviously, that is going to gain more interest over the next couple of years, because I mean, PPE is never going anywhere, even if hopefully the pandemic does. We've got 2 more talks of this series. So in a couple of weeks' time, so 2 weeks' time at a 9 a.m. UK time, so a different time slot. We've got a talk on brown adipose tissue. And then we're going to finish the second season with a talk 2 weeks after that on a more broad thermoregulatory topic linked to this book, which we will advertise. Registration will all be on the usual place, ice2021.com. So that's those 2 talks, and then that'll bring it a close for this season. As always, these 2 talks will be available on YouTube when Stephen has put them up. Thank you very much for your attendance, and thank you very much once more for Sarah and Yannick for your participation. You can all go and watch Tottenham now.
Thank you.